Hello everyone, how are you? Welcome back to my lecture series, and today I am going to talk about the electrocardiogram. So in the America it's known as EKG, and in the British system it is known as the ECG. Whichever way you feel good, you utter in that way. I will myself tell it in EKG because it's easier to pronounce it in EKG than ECG. My tongue actually trips when I say ECG, so it's better for me to say EKG. So to know about the EKG, you have to have a very basic understanding that heart is a pump, and it's an electrical pump like an electrical motor, and inside the electrical motor you have some generators that run the motor, and those generators create an electrical activity that run through some cables, and which are known as the conducting system of the heart, which is situated from the top to the bottom of the heart, so from the atrium to the ventricles, which carry the electrical activity to activate all the muscles of the heart and all the different chambers of that pump you got in your body. So here you can see a simple cross section of heart. This is actually, in medically, it's a coronal section of the heart, showing you all the ventricles and atriums and also the ventricular walls, and most importantly the conducting system that conducts the electrical activity from top to bottom of the heart. So this includes, and the top, it includes the SA node, the red dot here, and then AV node, then bundle of His, bundle branches right and left, and ultimately the Purkinje fibers. So as the generator starts up here in the top, and the SA node, which is also known as the pacemaker of the heart, this generator creates the electrical activity that travels through the atrial muscles and also the internal pathways to the AV node, and then it travels through the bundle of His and bundle branches and Purkinje fibers to activate the ventricular muscles. So you see that it's a top to bottom fashion, the electrical activity conductions, and this creates a mass of electricity throughout the heart, and this mass travels up fast from up to down, and this creates a huge voltage. I shouldn't say huge, it's a actually very low voltage. It's a low voltage throughout your heart, and it can be recorded by placing electrodes on your chest and other parts of the body, because your body, you know that your body is a conductor of electricity, a very good conductor of electricity, and so you can actually place an electrode on your body and you can see what's going on inside in the heart, or what kind of electrical activity is going on inside the heart. And if we place such an electrode, we get a diagram something like that. So this is a graph showing you a single heartbeat. So this is a single heartbeat, and in the horizontal axis you have the time. So this is the time for about a single beat, about 0.8 second or something, and in this 0.8 second a lot of events occur, and as I've already mentioned, the first electrical activity occurs in the atrium, and this atrial electrical activity produces a wave called the P wave. Then it travels to the AV node, stays for some few moments, and after that it causes a rapid electrical activity in the ventricles, causing another spike which is known as QRS complex, and ultimately it also causes another spike which is called a T wave. I'll explain all of those later. This is just a basic idea. So the electrical activity from above up going down to time, and if we measure, we see some mass of electrical activity producing some spikes. So this is one spike, another spike, and another spike. So those are actually spikes of electrical activity in different parts of the heart. So all of the heart is not activated at the single time. So some of the part of the heart is activated at some time, and then other parts are activated at later times. So those are showing you the electrical activity of different parts of the heart, but they are actually a cumulative measure of electrical activity inside the heart, especially inside the myocardium. So here is actually, you see a detailed view of a single heartbeat. So you can see multiple areas, the P wave, and then the PR interval, QRS complex here, and the ST segment, and the QT interval, and ultimately the T wave and also E wave. So I will explain every single bit of those parts in my later slides. So just stay put. And first we start with the P wave. So P wave is actually a wave of electrical activity that is actually present when the atrium is activated. So the atrial activation will be scientifically called a depolarization. So atrial depolarization will produce a P wave, and after the depolarization, which is about very tiny moment, about 0.1 second or something, or 0.2 seconds, actually it's repolarized, and the repolarization wave of the atrium is actually lost inside the next wave of electrical activity which occurs in the ventricles, producing a QRS complex. So QRS complex actually masks the atrial repolarization wave. And then after the P wave, you have the PR interval. So remember that after the wave of electrical activity reaches the AV node, it actually stays there for about 0.1 second or something. It is known as AV nodal delay. So this is a very important note to know. Make that the AV nodal delay is actually giving up the time for the ventricles to fill up before ejecting the blood through your aorta or pulmonary trunk. So the PR interval is a very important interval, and it's measured from the beginning of the P wave to the beginning of the QRS complex. So here, as you can see from this picture, the PR interval is measured from the beginning of the P wave to the beginning of the QRS complex. So this is very important, and this is actually measuring the time from atrial depolarization to the start of ventricular depolarization, and normally it is between 0.12 seconds to 0.2 seconds. So in an typical ECG graph paper, it will take a place of about 3 to 5 small box sides. So I will explain later how this came. And here you can see that this is the start of the P wave, and this is the start of a QRS complex, and in between this time is called a PR interval. And here you can see it actually occupied about 4 boxes, which actually about 0.16 seconds, and another one is also put here. QRS complex is the next to come to the P wave, and this is actually the largest spike we get always, because you have the ventricular muscles which are thicker, conducts more electricity, produce more electricity, and that's why it produces a large spike, and actually represents the activation of the ventricles, also known as ventricular depolarization. And its duration is shorter, which is about 0.1 seconds or 0.10 seconds, or in a typical ECG graph paper it will take about 3 small squares. And QRS complex has 3 pairs. As you can see, the fast negative deflection is called a Q wave, or upward deflection, and the next positive deflection or fast positive deflection is called an R wave, and the last negative deflection is called an S wave. And in some cases the QRS complex is entirely positive, and that is called an R wave, and in some cases the entire complex is negative, which is known as a QS wave, not just a Q wave. Okay, so this is the basic. So here you can see multiple nomenclature forms of QRS complexes. I think I shouldn't go into details, but simply the fast negative deflection is the Q, the fast positive deflection is the R, the last negative deflection is S. I think that's the basics that you need to know, but you can look up into the other parts that I've already put in the nomenclature list. You can easily understand them. So QRS width I have already mentioned, it is about 0.1 seconds, so it actually takes less than 3 boxes. So here it took 2 boxes, and it actually 2 boxes means 0.08 seconds, and here it took more than 3 boxes, or 3 boxes, which is about 0.12 seconds. So here the QRS is actually a bit prolonged. The QRS complex is followed by something called an XT segment, and which is the portion of the ECG cycle from the end of the QRS complex to the beginning of the T wave. So it actually represents the beginning of the ventricular repolarization. And normally ST segment is isoelectric, and it can be slightly elevated or slightly depressed, but it's always within a 1 millimeter area. So if it is elevated or depressed by more than 1 millimeter, it is actually pathologic. And there is another point to note, that the J point. So J point is actually a junctional point between the end of the QRS complex and the start of the ST segment. So it's a junction between QRS and the ST segment. So it's very important to know. And the T wave represents the ventricular depolarization. So here we can see the different parts. So if this is a QRS complex, this should be the end of the QRS complex and the beginning of the ST segment. So this junction is called a J point, and this is the ST segment, which is between the J point or between the QRS complex and the T wave. This is the ST segment, and then you have the T wave. Okay. The another important interval like the PR interval is the QT interval. So it measures the total electrical activity that goes on in the ventricles from the beginning of the depolarization to the end of the repolarization. So it is actually measuring the electrical activity from the or measuring the time of electrical activity from the QRS complex beginning to the end of the T wave, and it includes depolarization of the ventricles, mechanical contraction followed by depolarization, and ultimately repolarization. And as it's expected that if the heart rate increases, the QT interval will be shortened, and if the heart rate decreases, the QT interval will be lengthened. And as the QT interval actually differs greatly with the heart rate, we actually measure the calculated QT intervals, also known as QTC intervals. And to measure QTC, we divide the QT interval that we got in our graph or ECG graph by dividing with a root square of our intervals, and normally the QTC is about 0.33 seconds to 0.44 seconds. So QT can be prolonged in different conditions. I'm not going into that discussion right now. And next you have the U wave, which is a small rounded deflection which can be seen in some physiological and some pathological conditions after the T wave, and it represents commonly the last phase of the repolarization. If you have a very prominent U wave, commonly it suggests hypokalemia, and there are some drugs which can also produce an U wave like sotalol, phenothiazines, or even a cerebrovascular accident. And in appearance of very prominent U waves in such settings or without actual QT prolongation predispose patients to ventricular arrhythmias, so dangerous. So here we can see a very basic plot of an ECG graph paper, and you see in the ECG graph paper it is a graph that has many lines, horizontal and vertical like the normal graphs. It's a normal graph paper, and in the graph paper you will see something called a big box. So here you can see a big box, and inside a big box it is actually divided into 25 small boxes. Okay, so here a big box is actually taken out and shown zoomed in. We zoomed in a big box, and we see 25 small boxes which are actually square boxes, every one of them, and in those square boxes we actually measure the time. So the ECG paper is run through the ECG machine through a common time value or after a common time interval. So there is a regular speed of the traveling of ECG paper to the ECG machine, and that produces a typical recording of the ECG paper and typical timeline that we see in an ECG paper. So the time it takes for one large boxes to pass through the ECG machine is about 0.2 seconds. So within 0.2 seconds, a large box is passed through the ECG machine. So that's why a large box will tell you that it is actually 0.2 seconds. And inside the large boxes, horizontally you have 5 small boxes, and these 5 small boxes will actually take up each about 0.04 seconds to travel through the ECG machine. So one large box 0.2 seconds, one small box 0.04 seconds, and here you can see another thing that 3 seconds. So if we need 3 seconds, if we pass the graph paper, ECG graph paper through the ECG machine for 3 seconds, it will travel as much as about 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, and 15. So about 15 large boxes passes in about 3 seconds. And for 1 second you will have 5 boxes passing through the ECG graph paper or ECG machine. So I'm actually mixing it up to get you an idea of how we got this time manner. And this is about the horizontal axis, and in the vertical axis you have another small 5 boxes height, and this each of those boxes is denominated as a 1 millimeter box. So those are 1 millimeter box, and as the ECG is a time voltage graph, the time is plotted in the horizontal and the voltage is measured in the vertical area. So the 1 millimeter area will actually measure the voltage, and that produces a deflection, an upward deflection or a downward deflection. So those are the basics of the graph paper of an ECG. I think that clears this all. So the first thing we do after seeing an ECG is we calculate the rate that heart is pumping the blood. So there are two simple, very simple methods, and one is box counting method, and this is a very easy way, and can be done if the heart rate is regular. And what you have to do is we have to count the number of boxes between the two successive QRS complexes and divide it to a constant of about 300. So number of boxes between two QRS complex. Suppose in this here you can see a normal ECG, and here is one QRS complex and here is another QRS complex, and let us actually measure what are the number of large boxes in between those QRS complex. So I can see here about 1, 2, 3 and half, so about 4 large boxes. So 4 large boxes between two QRS complexes. So let us divide it to 300. So let us divide 300 by 4 and we get 75. So this patient is having a heart rate of 75 beats per minute, which is regular. Okay. And another important method is QRS counting method, which is actually very useful when the heart rate is irregular. Okay. So you can easily determine the average rate by counting the number of QRS complexes in some convenient time interval. So in every 10 seconds, the recording length of most clinical ECG records, and so measure the QRS complexes in 10-second interval and multiply this number by an appropriate factor, for example 6, to obtain in the rate per 60 seconds. So you measure the number of QRS complexes in 10-second interval and multiply it with 6. So you will get a rate per 60 seconds, because 60 seconds produces 1 minute. So if you see how many QRS complexes you get in 1 minute, it will tell you this is the heart rate. Heart rate is how many times the heart beats in 1 minute. So if you can measure hypothetically the beats in 60 seconds or 1 minute, or the QRS complexes in 1 minute, it will tell you the heart rate. So simple. So our interval is a very important interval, which is actually a QRS interval, and it is simply the distance between two consecutive equivalent points on the preceding or following QRS. And conveniently, R wave peak is chosen, but it is arbitrary. And there are some confusing terminology that the R interval is actually the QRS interval. The PR interval is actually onset of P wave, from the onset of P wave to the onset of QRS. The QT interval is really the onset of QRS to the end of the T. So it's actually not that standardized, and not every QRS complex has a Q, R, and S wave. So this is a last note. So ECG is a recording of cardiac electrical activity. It does not directly measure the mechanical function, so you cannot get any functional idea about the heart, especially how well the heart is pumping. Such as in patient with acute pulmonary edema may have a normal ECG, or in a patient who has a grossly abnormal ECG can have a normal cardiac function. And ECG does not record all the heart's electrical activity, and electrodes placed on the surface only records the currents that are transmitted to the area of electrode placement, and it records the sum or the total of the electrical potential which is actually produced inside the heart from the innumerable cardiac muscle cell. So there can be silent electrical areas. For example, parts of the muscle may become ischemic, and the 12-lead ECG may be entirely normal or show just non-specific changes. Okay, like the patient who is having an angina pectoris, but the ECG is normal. It can happen. So I think that's all from me today. Thanks for watching my video, and more videos on ECG, the in-depth videos of common clinical problems and clinical perspectives will be published very soon. Thanks for watching my video.